Welcome back to the deep dive. We have got a massive stack of notes, diagrams, and texts on the desk today, but we are doing something a little bit different.
Yeah, this feels a bit more focused than usual.
Exactly. Usually we take a broad, sprawling topic like the future of AI or, the history of geopolitics, and we swim around in it. But today
we are getting laser focused.
We're positioning this session specifically as a study companion. This is for the medical students, the surgical trainees, and, well, essentially anyone currently wrestling with that massive tome that is Baily and Love's Short Practice of Surgery.
It is a rite of passage, isn't it? If you're going to be a surgeon or even just a competent generalist, you have to get through Baily and Love. It's sort of the Bible of British surgery.
And today we are tackling a very specific part of it.
Yeah.
Chapter 62 from the 28th edition. The topic is venous disorders.
Right.
So think of this as your audio revision guide. We aren't just reading the chapter to you. We're interpreting it. We wanted to give you the mental anchors, the metaphors. The stories you need to make this stuff stick. For your exams, yes, but more importantly for when you're actually on the ward at 3 in the morning.
And before we cut into the anatomy, we need to be really clear about what this is and, maybe more importantly, what it isn't.
Good point.
Absolutely. While we are diving deep into the concepts in Chapter 62, this is our interpretation to help you understand it. It's a ready reckoner, a revision tool.
It doesn't replace the text.
It does not replace the text. You still have to open the book, look at the diagrams, especially the anatomy plates, and read the fine print. We're here to help you map the territory, not to replace the map itself.
Okay, disclaimer done. Let's start with the why. Why are we obsessed with veins today? I mean, in vascular surgery, arteries usually get all the glory.
Oh, for sure.
They're high pressure, they're dramatic, they spray across the room if you cut them. Veins seem a bit passive.
They do.
So why should a trainee care about this chapter? Is it just about cosmetic lumps?
That passive reputation is a really common misconception, and honestly, it's a dangerous one. Let's just look at the numbers in the source material. Baily and Love highlights that up to 40% of the adult population in resource-rich countries suffer from some form of leg vein disease.
40%. That is nearly half the people you see walking down the street.
It's huge. And the problem is it's so often dismissed as just cosmetic. Patients think, oh, I've got a few lumpy veins, I'll just wear long trousers.
Right. Hide it away.
But the impact on quality of life is massive. We're talking about chronic pain, heaviness, and the healthcare costs for the complications like ulcers are just astronomical. If you're a trainee, you will see this. It is bread and butter. You can't avoid it.
So we're going to unpack everything from the plumbing the anatomy to the really scary stuff like clots and ulcers.
Yep.
And you mentioned we're going to bust some myths. I know a lot of older textbooks and maybe some older consultants still talk about using tourniquets to diagnose varicose veins.
Yeah. And if you do that in a modern exam in an OSCE station, you might actually fail.
Really?
Oh, yeah. We're going to explain why we've moved on and why Mickey Mouse is probably the most important character in modern vascular diagnosis.
I am looking forward to the Mickey Mouse explanation. But let's start at the foundation. Part 1. The plumbing, anatomy, and physiology. The book describes the venous system of the lower limb, and honestly, lists of Latin names can get pretty dry.
They can't.
How do we visualize this so it actually sticks?
The best way to visualize the leg is as a two-system highway network. It's all designed to get blood back to the heart against gravity. So you have the deep system and you have the superficial system.
Okay, a highway network.
Yep.
Let's break down the deep system first. What's that one like?
The deep system is the high-speed freeway, the motorway. It runs deep underneath the deep fascia. And you need to remember that the deep fascia is that tough, connective tissue layer that surrounds all the muscle.
The stuff that contains everything.
It contains everything. And these deep veins are the heavy lifters. They handle the vast majority of the venous return. We're talking 85 to 90%.
Wow, okay.
And they accompany the arteries, which is a great mnemonic. So you have the venae comitants. Those are the paired veins that run right alongside the tibial and peroneal arteries down in the calf.
Venae comitants, that literally means accompanying veins, doesn't it?
Exactly. They're the entourage. They all merge together behind the knee to form the popliteal vein, which then shoots up the thigh to become the femoral vein. These veins are high volume, they're protected deep inside the muscle compartments, and they're under high pressure when those muscles contract. That's your freeway.
Okay, freeway deep under the muscle. So then what's the superficial system?
The superficial system is the scenic route. the aorode, if you like. These veins run in the subcutaneous tissue, much closer to the skin. But, and this is a really crucial anatomical detail from Baily and Love that often gets missed.
Okay.
They aren't just floating around randomly in the fat. The main trunks lie in what we call the saphenous envelope.
The saphenous envelope. That sounds like a piece of spy equipment. What is it?
It's a specific anatomical compartment. The vein itself is sandwiched between the deep fascia on the bottom and another layer called the saphenous fascia on the top.
Ah, so it's contained.
It's contained. And if you're looking at an ultrasound, this is what gives you the saphenous eye sign. It literally looks like an eye because the vein is the pupil, and it's caught between these two fascial eyelids.
That's a great visual anchor. So why does that matter clinically? Why do we care about the envelope?
Because that fascia prevents the vein from dilating too much. It gives it structure. If you see a vein that's outside that envelope just floating freely in the subcutaneous fat, it's a tributary, not the main trunk.
And tributaries behave differently.
They're much more likely to get tortuous and twisty because they don't have that same structural support. So knowing the difference actually changes how you treat it.
Okay, so inside the envelope, on the scenic route, we have the main players.
The two stars of the show are the great saphenous vein, or the GSV, and the small saphenous vein, the SSV.
The GSV is the big one. That's the longest vein in the body, right?
It is a classic exam question, and you need to be able to map its course mentally. It starts at the medial malleolus.
The inside ankle bone.
The inside ankle bone. It runs anterior to the malleolus, which is a key landmark because you can often find it there if you need emergency IV access. It then runs all the way up the inside of the leg and thigh.
And where does it end?
It ends at the groin, where it dives deep to join the femoral vein, and that specific meeting point is the saphenofemoral junction, or SFJ.
Medial malleolus to groin.
Ta.
Got it. And the small saphenous vein.
Think posterior. It starts at the lateral malleolus, the outside ankle bone, and runs up the back of the calf, right in the middle line of the calf muscle.
And that one joins behind the knee.
Usually, yes. It usually dives in behind the knee to join the popliteal vein. That's the saphenopopliteal junction, or SPJ.
But anatomy is rarely that clean and simple, is it? I think the book mentions a connector vein that sounds a bit like an Italian sports car.
The Giacomini vein. It does sound fast, doesn't it? But it's actually more of a bypass road. It's a variable finding. So sometimes the small saphenous vein doesn't just stop at the knee. It can send a cranial extension.
An extension heading up towards the head.
Exactly, up the back of the thigh, and it connects over to the great saphenous system. That connection is the Giacomini vein.
And why do I need to know about the Italian sports car vein?
Because if you're treating varicose veins and you ablate the short saphenous vein, but you miss the fact that it's feeding into a Giacomini vein, which is then feeding back into the great saphenous.
The pressure just finds another way.
It just reroutes,
Yeah.
and the patient's varicose veins might just come right back. You have to map the whole network.
Okay, so we have the freeway, which is the deep system, and the scenic route, the superficial. But there's a physics problem here. Gravity wants to pull all that blood down to the feet. What pushes it up? It's not the heart pumping it back, is it?
Correct. The heart pumps arterial blood to the leg. Getting it back is the job of what we call the peripheral heart.
The peripheral heart.
It's a calf muscle pump.
Right. And how effective is this pump?
Oh, it's incredibly powerful. It's purely mechanical. When you walk, your calf muscles, the soleus and the gastrocnemius, they contract. And that squeezes the deep veins inside those muscle compartments.
And liquids are incompressible.
Exactly. So that pressure just shoots up. We're talking 200 to 300 millimeters of mercury.
Wow. That's higher than systolic blood pressure. That is huge.
It blasts the blood upwards towards the heart. But the key to the whole system is what happens when the muscle relaxes.
You have to stop it from just falling back down again.
You do. And that's the job of the valves. The veins are lined with these bicuspid one-way valves. They're like check valves in plumbing. They ensure flow only goes in two directions, distal to proximal.
Up to leg.
And superficial to deep.
Wait, superficial to deep?
Yes. The whole point of the superficial system is to collect blood from the skin and fat and drain it into the deep system. So when the calf relaxes, the pressure in the deep veins drops, creating this vacuum effect. And it sucks blood in from the superficial veins through perforators.
Perforators are the little connector bridges between the scenic route and the freeway.
That's a perfect way to put it.
So it really is a pump and valve system. You walk, you squeeze, you push blood up, you relax, you suck blood in from the surface.
That's the whole game.
Okay, let's test this concept then. I'm going to throw a check-in question at you, and for you listening, see if you can answer this before the expert does.
Let's do it.
Check in. Question 1. If you were standing perfectly still, like a soldier on guard duty, what is the venous pressure in your foot compared to when you were walking?
That is the critical question. If you understand this, you understand the pathology. When you're standing still, the calf pump is off. So the pressure is basically just the weight of the column of blood from your heart down to your foot. It's hydrostatic pressure. And that's about 80 to 100 millimeters of mercury. It's high.
And when you start walking?
The moment you take a step, if your pump and your valves are working, that pressure should drop drastically. It should go down to about 30 millimeters of mercury or even less.
So walking effectively empties the leg.
Ideally. But, and here is the setup for all the disease we're about to talk about. If you walk and the pressure stays high, say it stays at 60 or 70 or 80, that is the definition of ambulatory venous hypertension, and that is the root of all evil in venous disease.
Okay, listener, if you didn't get that, rewind 30 seconds. Standing pressure is high, walking pressure should be low. If walking pressure stays high, you've got disease. That's the anchor concept.
It is.
So let's unpack that root of all evil. We're moving into part 2. When the system fails, pathophysiology. How does this all start?
Well, it's a vicious cycle. Imagine just one valve fails. Maybe it's genetic. Some people just have weaker collagen. Maybe it's age. Maybe it was damaged by a previous clot.
So one gate is broken.
One gate is broken. Now when the muscle pumps, instead of all the blood going up, some of it leaks back down through that broken valve. That is reflux. Retrograde flow.
Right, so the column of blood is now heavier than it should be.
It is. And this extra fluid volume sits in the vein segment below that broken valve, and that stretches the vein wall. Now the vein is wider. Because it's wider, the valve below that one can't close properly anymore. The leaflets just don't touch.
They're too far apart.
Too far apart. So that one fails and just cascades down the leg like dominoes. The pressure stays permanently high even when you're walking.
And this high pressure, this hypertension, is what damages the tissues. The book mentions a specific theory about how the tissue actually gets damaged. Something about white blood cells.
Yes, the white blood cell trapping theory. It's a bit of a historical note now, but it's still really important for understanding the damage mechanism. The theory was that because of the high pressure, the blood flow slows right down in the capillaries, and white blood cells would get stuck or trapped.
They're too big to get through.
They couldn't move through easily, so they would become activated, release all these inflammatory enzymes, proteolytic enzymes, and basically eat the tissue from the inside out.
So the body is attacking itself because of a plumbing problem.
Essentially, yes. Now, while the exact trapping mechanism is debated, we know it's a bit more complex than that, the core concept holds up. Ambulatory hypertension causes chronic inflammation. Capillaries get damaged, fibrin leaks out and forms this cuff around the vessels, and that cuff prevents oxygen from getting from the blood to the skin. The tissue starts to suffocate.
And this leads to all the visual signs we see in the clinic. The book lists a spectrum. Let's walk through them from mild to severe so our listeners can picture this on a real patient.
Sure. It usually starts with telangiectasia.
Spider veins.
Spider veins. Less than 1 millimeter. They're red or purple. Usually patients are worried about how these look, but on their own, they aren't medically dangerous.
Then they get a bit bigger.
Then you get reticular veins. These are the blue, sort of feathery ones, 1 to 3 millimeters. They're often the feeders for the spider veins.
And then we get the classic lumps.
Varicose veins, defined strictly as subcutaneous, palpable, and greater than 3 millimeters in diameter. These are the ones that bulge out like ropes or bunches of grapes under the skin.
But the real danger signs, the ones that tell a surgeon this leg is in trouble, they show up on the skin itself, right? Specifically in the gaiter area. Remind us where the gaiter area is again.
It's the zone between the ankle and the main bulk of the calf muscle. Think of where a soldier would wear a gaiter or a boot, or where a soccer player wears a shin guard, but a bit lower down. This is where the hydrostatic pressure is highest, just due to gravity. So this is where the damage shows up first.
Okay, so what are the big warning signs a student should be looking for in that zone?
There are 4 big ones that Chapter 62 highlights. First, corona phlebitictatica.
That's dramatic.
It's the malleolar flare. It's a fan-shaped pattern of spider veins right at the ankle. If you see that, it's not just a simple spider vein. It is an early sign of advanced system failure. It's basically the skin screaming that the pressure at the ankle is too high.
Okay, warning sign number 1. What's number 2?
Hemosiderosis. This is the brown staining of the skin.
Why brown? Why not red or blue like a bruise?
Because red blood cells are leaking out of these high-pressure capillaries into the skin. They die and break down. The hemoglobin releases its iron, which is hemosiderin, and iron is brown or orange. It's like a permanent tattoo of rust in the skin. You can't wash it off. It indicates chronic bleeding into the tissue.
Rust in the skin. That is a very vivid image. What's the third one?
Lipodermatosclerosis, or LDS. This one is critical. The chronic inflammation makes the subcutaneous fat and the skin hard, fibrotic, and contracted. The text describes it as a woody leg. If you touch it, it feels hard like a table leg, not soft like skin.
The champagne bottle leg.
Exactly. The ankle is thin and tight because of all the scarring, and the calf bulges above it. It looks just like an upside-down champagne bottle. It can get so tight, it actually pulls on the Achilles tendon and limits movement.
And the final one.
Atrophy blanche. These are white, scarred patches of skin. It looks like porcelain or ivory. It's a sign of severe ischemia, a real lack of blood supply in that specific spot. It's often a precursor to an ulcer. If a patient scratches that area, it will not heal.
The book also briefly mentions a classification system, CEAP. We don't need to memorize the whole table right now, but what's it for?
CEAP. It stands for Clinical, Etiological, Anatomical, and Pathophysiological. It's just the standard language we use. So instead of a surgeon writing bad veins with skin changes, they can write C4A. And any vascular specialist in the world knows that means pigmentation and eczema. It just standardizes research and treatment, so we're all comparing apples to apples.
All right. Okay, time for check-in question 2. You are examining a patient. Their lower leg feels hard, almost like wood, and there's a distinct brown discoloration around their ankle. What is the specific medical term for this woody change, and what does it tell you about their disease state?
The term is lipodermatosclerosis, or LDS, and what it tells you is that this patient has severe chronic venous disease. They are in the danger zone for developing an ulcer. The skin is failing.
Excellent. Let's move on to part 3, varicose veins, the diagnosis and the treatment. And I want to introduce a case study here to ground this discussion.
Good idea.
Case study A. We have a 45-year-old chef. Let's call him Marco. He works 12-hour shifts on his feet. He comes in saying his legs ache, they feel heavy, and they throb. And it's way worse at the end of a long Friday night shift. He also has visible bulging veins on his inner thigh.
This is a classic presentation. Yeah. The chef aspect is so relevant because of the prolonged standing. He's essentially removing the benefit of his calf muscle pump for hours at a time, just letting that pressure column sit on the valves.
He's not walking enough to pump it out.
Exactly. And his symptoms, heaviness, aching, throbbing, they sound a bit vague.
They do.
Which is why the history is so key. Venous symptoms are often described that way. But the key differentiator, the one question you absolutely must ask Marco is, does it get better when you put your feet up?
And why is that the magic question?
Because if he puts his legs up, gravity helps drain the blood and the pain goes away. If it was arterial pain claudication from a lack of blood flow elevation would usually make it worse.
Because you're fighting gravity to get blood to the feet.
Right. Arterial patients dangle their legs over the side of the bed. Venous patients prop them up on pillows.
Okay, so Marco's in your clinic. How do you diagnose him? Now, in the old days, and in some old exam stations, you'd tie a tourniquet around his leg and watch which veins fill up, wouldn't you? The Trendelenburg test.
No, stop. Baily and Love is very, very clear on this. Tourniquet tests are historical. They have been abandoned in modern practice. They are inaccurate, they're subjective, and frankly, they're just confusing. Do not do them. If you start tying rubber bands around a patient's leg in a clinic today, your consultant will look at you very strangely.
So what is the gold standard now?
Duplex ultrasound. You have to see inside the leg. And this brings us, finally, to the Mickey Mouse sign.
Explain this. How does a cartoon character help us do surgery?
It's the view you get when you put the ultrasound probe transversely sideways in the groin crease. You see 3 dark circles on the screen. The big face in the middle is the common femoral vein.
Okay.
One of the ears, usually lateral, is the common femoral artery. And the other ear, the medial one, is the great saphenous vein as it joins the femoral vein.
So it looks like Mickey's head.
It looks exactly like Mickey Mouse. And if you see Mickey, you know you are precisely at the saphenofemoral junction. You hold the probe there, you get the patient to squeeze their calf, and you watch the blood flow using Doppler color.
And what are you looking for? What's the sign of disease?
You're looking for reflux. When you squeeze the calf, blood shoots up towards the probe, which shows up as blue on the screen. That's normal. When you let go, it should stop immediately because the valve should snap shut.
But if it's broken,
If the valve is broken, the blood falls back down, away from the probe, which shows up as red. If that red retrograde flow lasts for more than half a second, 0.5 seconds, the valve is incompetent. That's the definition.
Okay, so Marco has reflux greater than zero point 0.5 seconds. He officially has varicose veins. How do we treat him?
We have a management hierarchy. At the bottom, we have compression hosiery, stockings.
Do they work?
They are great for symptoms. They squeeze the leg, they help the pump. But, and this is a really big but, they do not fix the underlying problem. They don't make the varicosities go away, and compliance is notoriously poor.
People just don't wear them.
They're tight, they're hot, they're hard to put on. Marco, working in a hot kitchen, is probably not going to wear tight stockings every day.
Makes sense. So if he wants them fixed for good.
The modern gold standard, what NICE recommends, is endothermal ablation. This includes EVLA, which is endovenous laser ablation, or RFA, radiofrequency ablation.
And how does that work?
We cook the vein from the inside. You insert a long catheter into the vein under ultrasound guidance, usually entering near the knee. You thread it all the way up to the groin, just shy of the junction. Then you fire it up, either with laser or radiofrequency energy. And as you pull it out slowly, the heat destroys the protein in the vein wall.
It just seals it shut.
It causes it to shrink and seal shut. The body then eventually just absorbs that fibrosed vein. It turns into a scar cord and pretty much disappears.
But wait, you're burning a vein inside the leg. Doesn't that hurt? Or damage the skin? Or the nerves that are sitting right next to it?
That is where tumescent anesthesia comes in. This is the crucial safety step. Before you fire the laser, you inject a large volume of dilute local anesthetic liquid all around the vein, inside that saphenous envelope we talked about. It looks like a halo on the ultrasound screen.
And it has 3 jobs, right?
3 critical jobs. 1, it numbs the leg so the patient doesn't feel the burn. 2, it compresses the vein so it's empty of blood. Lasers work much better on the vein wall than on a column of blood.
And 3.
And 3, it acts as a heat sink. It's a water cushion. It absorbs all the excess heat so you don't burn the skin or the saphenous nerve that runs right alongside the vein. It isolates the burn to just the vein itself.
That's fascinating. It's like a protective halo of water.
Mm-hmm.
What if a patient doesn't want heat? Are there other options?
There are non-thermal options. One is foam sclerotherapy. You take a sclerosant drug, something like sodium tetradisyl sulfate, and you mix it with air to make a foam.
The Tessari method.
That's the one. You pump it between 2 syringes, you inject the foam, and the chemical destroys the vein lining. It's great for very twisty, tortuous veins where a stiff laser catheter can't go, but generally it has a slightly higher recurrence rate than laser.
Any others?
There's also glucyanoacrylate. You literally glue the vein shut from the inside. The advantage is no heat, so no risk of nerve burn, and you don't need all that tumescent anesthetic.
What about the old way, the high-tine strip? I feel like everyone's grandmother had their veins stripped.
Open surgery. This involves making a cut in the groin, finding the saphenofemoral junction, tying off all the branches, and then physically stripping the vein out of the leg using a wire stripper.
It sounds brutal.
It works, but it's traumatic. You have a general anesthetic, significant bruising, a recovery period of weeks, and there's a real risk of nerve injury.
Which nerves are at risk?
If you strip the great saphenous vein, the GSV, you risk damaging the saphenous nerve. That causes numbness on the inner part of the ankle. If you operate on the small saphenous vein, the SSV, you risk the sural nerve, which causes numbness on the outer part of the foot.
So because of those risks and the recovery time,
endothermal ablation has largely replaced open surgery. It's a walk-in, walk-out procedure. Marco can go back to cooking much, much sooner.
Right. Let's move on to the grim reality of untreated venous disease. Part 4. Venous leg ulcers.
This is serious business. The stats are really clear. 85% of all leg ulcers are venous in origin. If you see a leg ulcer, statistically, it's a vein problem until you prove otherwise.
And why do they happen?
It all comes back to that ambulatory venous hypertension. The high pressure destroys the skin quality over years until it just breaks down. It's the end stage of that process we discussed earlier, the rust, the woody skin, and then eventually the tissue dies and creates a hole.
So how does a student recognize a venous ulcer compared to, say, an arterial one? They can look similar to the untrained eye.
It's all about location and look. Location, almost always in the gaiter area and classically near the medial malleolus, the inside ankle bone. Arterial ulcers are more often on the toes, the heel, or other pressure points.
And the appearance.
A venous ulcer is typically shallow with sloping edges. I tell students to think of a gentle beach. The base is often red and granulating. It's trying to heal, or it's covered in yellow slue. Compare that to an arterial ulcer, which is often described as punched out.
Like a cookie cutter.
Exactly. Deep with vertical sides, and they're often pale, dry, and incredibly painful.
The book has a specific and pretty scary warning about something called a Marjolin's ulcer.
Yes. This is a crucial point. If you have a patient with a chronic ulcer that's been there for years and it suddenly changes its appearance, maybe the edges start to roll up or it gets lumpier or it starts bleeding easily, you must biopsy it.
Why?
It could have transformed into a squamous cell carcinoma. That is a Marjolin's ulcer. It's a malignancy arising in a chronic wound. You can never assume a changing ulcer is benign.
Okay, so how do we treat a standard benign venous ulcer?
The prime directive is compression. You have to counteract the internal high pressure with external pressure. You need to squeeze the leg harder than the veins are pushing out.
And the gold standard for that is the 4-layer bandage.
It is. Layer 1 is wool for padding and absorption of any fluid. Layer 2 is crepe, just to smooth it all out. Layer 3 is an elastic bandage. That's what provides the real squeeze. And layer 4 is a cohesive bandage to hold it all together.
What kind of pressure are we aiming for?
About 35 to 40 millimeters of mercury of pressure at the ankle. And that pressure should graduate. It should get less as you go up the leg.
But there's a trap here.
Yeah.
A really dangerous trap.
A huge trap. Before you put any compression on a leg, you must check the arterial supply. You have to check the ABPI, the ankle brachial pressure index.
Why is that so important?
Well, think about it. What if the patient has mixed disease? What if they have bad arteries as well? They might have low blood pressure in their leg arteries. If their ABPI is, say, 0.4, and you put a tight compression bandage on, that creates 40 millimeters of mercury of pressure.
You've just cut off their blood supply.
You might exceed their arterial pressure. You will cut off the blood supply completely. You can turn a venous leg ulcer into a gangrenous leg that needs an amputation.
So rule 1, check the pulses, check the ABPI.
Always. If the ABPI is less than 0.8, you have to be careful. If it's less than 0.5, high compression is absolutely contraindicated. You will kill the leg.
What about surgery for ulcers? Can we fix the veins to help heal the hole?
Yes. This was proven by the ESHAR study, which is a landmark trial you should know. It showed that if you treat the underlying superficial venous reflux with ablation or surgery in addition to compression, you don't necessarily heal the ulcer faster initially, but you significantly reduce the chance of that ulcer coming back, so you fix the plumbing to keep the skin healed long term.
Okay. Let's move on to part 5, venous thromboembolism, or VTE. This is a big topic.
It is.
Let's use another case. Case study B. A patient, let's call her Mrs. Jones, had hip surgery 3 days ago. She's recovering on the ward, but now she has a swollen, painful red calf.
Classic deep vein thrombosis, a DVT presentation. This is the flip side of venous disease. It's not about reflux, blood falling down. It's about blockage, blood getting stuck.
And for this, we have to talk about Virchow's triad. This is the holy trinity of clot formation, isn't it?
It is. Rudolf Virchow, back in the 19th century, he identified 3 factors that lead to thrombosis. 1, stasis, blood that isn't moving. Mrs. Jones is bedbound after her surgery.
Check.
2, endothelial injury, damage to the vein wall. The surgery itself causes trauma and inflammation.
Sure.
And 3, hypercoagulability, thick, sticky blood. The body reacts to surgery by increasing clotting factors to stop bleeding, but that also increases clot risk. Or maybe she has an underlying condition like cancer or factor V Leiden. So Mrs. Jones has at least 2 of the 3.
So how do we diagnose it? Can we just look at the leg and squeeze it? What about Hohen's-sign?
Hohen's-sign pain on dorsiflexion of the foot is historically interesting but clinically useless. Don't rely on it. Clinical diagnosis is notoriously unreliable. You can have a massive DVT with no symptoms at all, or a painful leg that's just a muscle strain, or a Baker cyst rupture.
So what do we use?
We use the Well score to stratify their risk. It's a scoring system that gives points for things like active cancer, calf swelling greater than 3 centimeters, recently bedridden.
And if the Well score is low?
If the probability is low, we might use a D-dimer blood test.
Explain D-dimer. It can be confusing.
It can. D-dimer is a protein fragment that's produced when a blood clot is breaking down. So it has very high sensitivity but very low specificity. Meaning if it's negative, there's no clot. It's a great rule-out test. You can send the patient home. But if it's positive, it just means there is some inflammation somewhere. It could be a clot, but it could also be infection or just the post-surgery inflammation itself.
So if the D-dimer is positive or the Well score is high, You need imaging.
You do. Ultrasound again. But it's a different kind of scan from the varicose vein one. It's a compression ultrasound. The sonographer literally tries to squash the vein with the probe.
And if it squashes?
If the vein collapses completely, it's patent, it's open. If it doesn't compress, if it stays around like a hose pipe when you push on it, there's a solid clot inside holding it open. That's a diagnosis.
And on the treatment?
Anticoagulation. We have to thin the blood. This stops the clot from getting bigger and, crucially, prevents it from breaking off and traveling to the lungs, which would be a pulmonary embolism. We let the body's own lytic system dissolve the existing clot over time.
So we use things like low molecular weight heparin injections or the newer oral anticoagulants.
Exactly. The DOACs, like rivaroxaban or apixaban.
There is a terrifying condition mentioned in the chapter called phlegmasia cerulea dolens. What on earth is that?
The painful blue leg. This is a massive proximal DVT, usually in the iliofemoral segment, up in the groin and pelvis. It blocks almost all the venous return from the leg.
So the leg just fills with blood.
It does. The pressure gets so high in the leg that it actually exceeds the arterial pressure. It stops arterial blood from getting in. The leg turns blue, it swells massively, and it is agonizingly painful. It is a surgical emergency because it leads to venous gangrene.
So you can't just give pills for that?
No. You might need to physically remove the clot, a thrombectomy, or use catheter-directed clot-busting drugs, thrombolysis, to dissolve it rapidly before the leg dies.
That sounds like an absolute nightmare scenario.
Yeah.
Okay, let's wrap up with part 6, the zebras. The more niche conditions mentioned in the chapter.
Let's hit 3 of them quickly. First, pelvic congestion syndrome.
Who gets this?
The typical persona is a premenopausal woman who has had multiple children. She presents with this chronic, dull, aching pelvic pain that gets much worse when she stands for a long time.
And what's the cause?
It's basically varicose veins inside her pelvis, around the ovaries and the uterus. The ovarian vein valves fail.
Yeah.
It's the exact same pathology as varicose veins in the leg. It's just hidden inside.
Okay. Next zebra. The weightlifter with a swollen arm.
Axillary vein thrombosis, also known as Paget-Schroeder syndrome. It's a DVT in the arm or shoulder, and it usually happens in young, healthy people who do vigorous upper body activity, weightlifting, rowing, baseball pitching.
Oh, that's...
The vein gets pinched between the first rib and the clavicle in the thoracic outlet, and that trauma, plus the exertion, causes it to clot off.
And the final one involves a port wine stain.
Klippel-Trenaunay syndrome. It's a congenital triad of symptoms. You need to know the triad. 1, a port wine stain, which is a capillary nevus. 2, varicose veins. And 3, limb hypertrophy.
Meaning one leg is bigger or longer than the other.
Exactly. Bony or soft tissue hypertrophy. Management for that is usually conservative, lots and lots of compression.
Wow. We have covered a massive amount of ground, from the peripheral heart in the calf to the Mickey Mouse sign in the groin and the dangers of the woody leg.
We have. Venous disease is complex, but it follows the rules of physics and plumbing. If you can understand the pressure gradients and the anatomy, the pathology really does make sense.
Okay, let's summarize the key takeaways for everyone's revision notes.
Yeah.
What are the absolute must-knows?
Okay, 1, anatomy. The deep system is the freeway. The superficial is the scenic route. And you have to know your junctions, the SFJ and the SPJ.
So,
Diagnosis, throw away the tourniquet, use duplex ultrasound, look for Mickey Mouse.
3.
Treatment, endothermal ablation, so laser or RFA, is the gold standard for varicose veins now. It's less invasive and safer than stripping.
And finally, 4.
Ulcers. Compression is the cure, but, and I can't say this enough, check the ABPI first or you might kill the leg.
Absolutely spot on. Now, before we go, I want to leave our listeners with a provocative thought from the chapter. Something to chew on.
Yes. It's about the mystery of the ulcer. We know that high pressure causes ulcers. We're very good at treating that, but we still don't fully understand the cellular how. The white cell trapping theory was a good attempt, but it's not the whole story.
It's more complicated.
It's a complex biochemical soup of enzymes, free radicals, and senescent fibroblasts in that wound. We treat the macrophysics, the compression, but the microbiology is still a frontier. It's waiting for one of you listening to solve it.
I love that. Maybe a future Nobel Prize winner is listening to this right now.
You never know.
All right, that is it for this deep dive into Baily and Love Chapter 62. Here is your call to action. We have given you the map. Now you have to walk the territory. Open the book. Look at the diagram of the 4-layer bandage. Look at the anatomical variations of the short saphenous vein. We mentioned it's variable. Go see how variable it can be. Visualizing it is the only way to make it stick.
Good luck with your revision.
Thanks for listening. We'll see you in the next deep dive.